afternoon, everyone. I'm Dr. Vaibhav Mohanty. I'm an orthopedic foot and ankle surgeon practicing here in Bhubaneswar. Before I start my talk, I would like to thank Sarthak Patnaik sir for conducting this beautiful conference and for giving me this opportunity to speak in front of you all. Thank you so much. Well, the topic of my presentation is management of Haglund's deformity. Well, I'm going to discuss about all the surgical options after we have exhausted all the conservative methods. So here, what all options do you have? The traditional open technique, the endoscopic calcaneoplasty, minimally invasive Haglund dissection using Shannon burrs, endoscopic calcaneoplasty with limited tender Achilles debridement and reattachment, and this is something new, ZX osteotomy, and finally, FHL transfer. But before we go into the surgical part, what you must not miss in clinical evaluation. While checking clinically, you should know whether it is just Haglund deformity with retrocalcaneal bursitis or the tender Achilles at the insertion is also degenerated. And apart from that, whether the alignment is normal or not, whether it is cavus or planus and the gastroc tightness is there or not. And radiologically, there are many parameters, but the bump height and the to calcaneus ratio, they strongly correlate with the amount of degeneration at the insertion of the Achilles tendon. And in the MRI, if the Achilles thickness is more than 6.1 mm, around 2 centimeters above its insertion, that means there is good amount of degeneration. And if the amount of degeneration is more than 50%, the chances of failure with endoscopic procedures is quite high. But that is slowly changing nowadays. So let's start with the traditional open technique. You could go ahead and do a central midline incision, tendon splitting, go in, take out the bone, take out the bursa, and finally reattach the tender Achilles. But we know the chances of wound dehiscence is quite high in the open technique. Next comes the endoscopic calcaneoplasty. So in cases of only Haglund deformity with some amount of retrocalcaneal bursitis, we can go ahead and use a 2.7 mm scope or a 4 mm scope and just shave off the bone and take out the bursa. So this has already been discussed, the position of the patient, the portals and how it looks inside. And the amount of the bone resected has already been shown by people who spoke before me. And the endoscopic calcaneoplasty has demonstrated a 204% increase in Achilles pull-out strength in comparison to open midline splitting calcaneoplasty. And as we have seen, there is a good amount of reduction in the post-operative complications from 12.3% to 5.3% using an endoscopic approach compared to the open approaches. Now continuing with this, since it's an arthroscopy conference, I would also like to tell you can go ahead and do minimally invasive Haglund dissection using Shannon burrs. So in case of arthroscopy, you were making 2 portals by the side of the tender Achilles. Here, you can make a small nick on the lateral side by the side of the tender Achilles, and using the Shannon burr, you can shave off the bone. If there is some amount of degeneration, definitely you can go ahead with the endoscopic calcaneoplasty along with limited tender Achilles debridement and reattachment. This is how it looks like. And up to 50% of the tendon can be resected from superior to inferior margin quite safely. Patients with degenerative changes in the Achilles tendon, they have poor subjective outcomes following endoscopic surgery. But this is an old paper, now it is rapidly changing. Now this is something new, ZX osteotomy. You can do it either open or in minimally invasive way. Here what we do is, it is basically a dorsal closing wedge osteotomy of the calcaneus. So what it does is, it rotates the Achilles insertion anteriorly, decompresses the posterior heel, functionally lengthens the gastroc complex, which in turn improves the dorsiflexion and relieves the pathological strain at the Achilles insertion. And this is how we do it. Using Shannon burr, we remove the Haglund, then dorsal closing wedge osteotomy is done, which is closed and finally fixed with screws. Now, this technique obviates the need for a gastroc recession as the patient on average gains around 7 degrees of dorsiflexion compared to the baseline. And most importantly, the Achilles insertion remains untouched during the whole osteotomy. It can be done for patients who present with insertional Achilles tendinitis, including those with substantial insertional calcification. We are not touching the tender Achilles insertion at all. And finally, if the tendon is too much degenerated, this is what we have been doing, removing the whole tendon and doing an FHL transfer. But again, as shown by Anuj sir, we can do it endoscopically also. So the wound complications is less. So to conclude, Haglund deformity with no tendinopathy, you can go ahead and do endoscopic calcanoplasty or a minimally invasive Haglund dissection using Shannon burrs. If there is mild tendinopathy, you could do endoscopic calcanoplasty with limited debridement and reattachment, or you could try ZX osteotomy. If there is moderate amount of tendinopathy, you could extend the indication of ZX osteotomy, or if you are not comfortable with it, you can just open dissection and reattach. And finally, if there is Haglund with attritional lengthening or severe tendinopathy involving more than 50%, open FHL would be better. But if you are good enough with your arthroscope, you could go ahead and do endoscopic FHL transfer. Thank you so much.